Obamacare's marketplaces were supposed to give consumers choices of health plans from insurers that compete to keep premiums down. But fewer insurers seem to be participating, and premiums are increasing sharply. Fixing this problem will obviously be politically difficult, with a Republican-controlled Congress that has vowed to repeal and replace. President-elect Donald Trump has also said he wants to get rid of the ACA, although he amended that recently by saying he'd like to keep some elements. Replacing the law without a Senate supermajority would also be politically difficult. From a policy standpoint, however, some solutions to problems facing the marketplaces are ones that Republicans have endorsed before, for Medicare. That's the topic of this week's Healthcare Triage. Special thanks to Austin Frack, from whose column this episode was adapted. The number of insurers participating in the Obamacare marketplaces has been falling. Last year, 182 counties had only one insurer offering plans. This year, that will be true of nearly 1,000 counties, or almost 1/3 of the total. An average marketplace is offering 17 fewer plans in last fall's open enrollment period than the year before's. Fewer choices make it harder for consumers to find plans that meet their needs, like including doctors and hospitals they prefer and covering the drugs they take. Shrinking choice isn't the only problem facing the marketplaces. On average, the most popular type of plan will cost about 22% more this year than last year. However, in some regions, premium increases are much larger. Residents in Phoenix are seeing a 145% rise. In some regions, increases are low. Columbus, Ohio, for instance, is facing only a 3% increase. Insurers' exits and rising premiums are related. Both are happening because the number of enrollees and their healthcare needs are not what insurers expected. One piece of evidence that this occurred is that the Obamacare marketplace plans attracted more older people than the administration's initial projection. Another factor, in states that did not expand their Medicaid programs, some sicker, higher-cost consumers that would otherwise be Medicaid eligible are in marketplace plans. If insurers attract too few consumers with little or modest health needs and instead attract a larger proportion of sicker ones, healthcare costs outstrip premium revenue. In the worst case, an insurance company throws up its hands and exits the market. Some insurers that have left Obamacare markets stated that they did so because they couldn't earn enough money to keep up with costs. Increasing premiums might close the revenue cost gap. However, premium increases can further discourage consumers, particularly healthier ones, from enrolling, which makes the whole thing worse and eventually gets to what we call a death spiral, and we've talked about that before. As competition decreases, the remaining insurers have greater market power to increase premiums. States with the fewest insurers have the largest premium increases, while those with more insurers have had more modest premium growth. Those facts are consistent with findings from both government and non-government organizations. A recent study in the American Journal of Health Economics illuminates the competition premium connection. Researchers found that premiums in the first year of the marketplaces were 5.4% higher just because one national insurer opted out. Another study, published in Health Affairs, found that premiums fall by 3.5% with the addition of another insurer. All of this, insurer withdrawals and sharply escalating premiums, was avoidable and is fixable. We know how to draw insurers into markets, keep them there, and limit premium growth. We can do so by subsidizing plans more and by limiting their risk of loss. We've done both of these things before. In the early 2000s, Medicare Plus Choice, then the name of what is now the Medicare Advantage program, which offers private plan alternatives to traditional Medicare, was struggling. The proportion of Medicare beneficiaries with access to a Medicare Plus Choice plan declined from 72% in 1999 to 61% in 2002. The number of plans offered dropped 50% and enrollment dropped 21%. Insurance industry representatives said that the problem was that government subsidy payments to plans were not keeping up with costs. After payments to plans drastically increased as part of the 2003 Medicare Modernization Act, passed by a Republican Congress and signed by President George W. Bush, insurers flooded the market. This was controversial. Members of Congress from both parties expressed concern that plans were overpaid, wasting taxpayer resources. But by 2007, every Medicare beneficiary had access to at least one plan. The market stabilized, so much so that even as payments to plans were cut by the Affordable Care Act, plan enrollment continued to grow. Today, about 1 in 3 Medicare beneficiaries is enrolled in a private plan, a record high. Increasing the subsidization of Obamacare plans might have the same effect, reducing costs to consumers and drawing more of them and insurers into the market. The Medicare Modernization Act also established Medicare's prescription drug program, Part D, which offers another lesson. It's also run entirely through private plans. They're cushioned against large losses by a risk corridor program. This helps plans stay in the market if they miscalculated the mix of patients they'd attract, and it allows them to keep premiums lower than they might need to if they had to hedge against the full brunt of potential losses. The Affordable Care Act included a risk corridor program for marketplace plans too, but it expired at the end of last year. So does a reinsurance program that compensates insurers for unusually high-cost enrollees. Following the model of Part D and making the risk corridor program permanent, as well as the reinsurance program, could help stabilize the marketplaces. There are other ways to shore up Obamacare. Including a public option in the marketplaces would increase competitive pressure. Public option means having the federal government offering insurance plans, providing an additional choice, or choices if the government offered multiple plans. If plans included more doctors and hospitals in their networks, it might pull more expensive patients from private plans as well, reducing the risks. Another idea is to require insurers to participate in broad regions, which would limit their ability to selectively work in more profitable ones and shun ones that are less so, like rural areas. This would be consistent with Medicare Part D, which requires insurers that offer standalone drug plans to do so in multi-state regions. Yet another approach is to increase the penalty for issuing coverage, which for many people is cheaper than buying insurance. Here again, we could look to Medicare, which includes penalties, which grow the longer one waits for failing to enroll in coverage for physician services or drugs. There's one significant problem with all these ideas, of course. They'd need to pass the Republican Congress and be signed into law by Mr. Trump. Though the GOP has endorsed some of the ideas before, for Medicare, it's a safe bet they won't do so for the Affordable Care Act. Time will tell. Healthcare Triage is supported in part by viewers like you through patreon.gov, a service that allows you to support the show through a monthly donation. Your support makes this show bigger and better. We'd especially like to thank our research associate Joe Sevitz and thank our Surgeon Admiral Sam. More information can be found at patreon.com/healthcaretriage.